Good morning. We're about to begin. Raise your hand if you're able to hear me clearly. All right, that's good enough. All right, this morning we'll be looking at communication and documentation. Then we'll be looking at lifting and moving. It's going to be a tedious chapter, but we will work our way through. Right, introduction. Communication is the transmission of information to another person, and it can be verbal or nonverbal through body language. Verbal communication skills are important for an EMT. So it's very important that you're able to communicate effectively with your patient and with your peers. It will enable you to gather critical information, coordinate with other responders, and interact with other healthcare professionals. The importance of documentation. So documentation is going to capture the patient's permanent medical record. It demonstrates appropriate care was delivered. So if it wasn't documented, it wasn't done. It helps others in patients' future care, so it can be used for capturing data for research purposes. It completes patient records, so it guarantees proper transfer of responsibility. It complies with requirements for health departments and law enforcement agencies, and it fulfills your organization's administrative needs. Now, radio and telephone communication. Link the EMT to EMS, fire department, and law enforcement. You must know or be familiar with what your system can and cannot do, and how to use the system efficiently and effectively. Now, let's look at therapeutic communication. Therapeutic communication uses various communication techniques and strategies. It is a combination of verbal and nonverbal. It encourages patients to express how they feel and achieves a positive relationship with each patient. As EMS providers, we need to be familiar with the Shannon-Weaver communication model, which is widely known. So there is a sender that takes a thought. That thought is then encoded into a message. The message is then sent to the intended person or the receiver. The receiver then breaks down that thought or decodes that message, and then determines a feedback, right? And once the feedback is decided, it is sent to the sender or sent back to the sender. Now, factors that can influence or affect communication: age, body language, clothing, culture, education, environment, eye contact, facial expression, gender, posture, voice tempo, volume. So age, culture, and personal experience shape how a person communicates. Body language and eye contact are generally affected by culture. So there are some cultures that think it's impolite to have direct eye contact, and there are others that think it is not. Tone, pace, and volume of language reflect mood of the person and perceived importance of the message. Now, ethnocentrism is considering your own cultural values more important than those of others. Cultural imposition is forcing your values onto others. Now, nonverbal communication. Body language provides more information than words alone. Even without exchanging any words, you should be able to tell the mood of your patient. Facial expressions, body language, and eye contact are powerful communication tools, and it will help people to understand messages being sent. And be careful with the body language because sometimes it can be misinterpreted. When treating a potentially hostile patient, be aware of your own body language. And you cannot meet hostility and aggression with aggression. You have to be passive, and be aware of your distance between you and that patient. Right? So a patient that is behaving aggressive or hostile, you need to maintain what we call in martial arts striking distance. So that person should not be within your striking distance. Stay calm and try to diffuse the situation. Assess the safety of the scene. And you don't want a patient that is showing any signs of aggression or hostility to be between you and your exit, right? Don't want that to happen. Do not assume an aggressive posture. And as I say, you want to maintain arm's length or 2 times your arm's length between you and that patient. It is possible that that distance can be breached. And if that distance is breached, meaning the person is within striking distance, then your arms should not be below your waist. Make good eye contact, but do not stare. Speak calmly, confidently, and slowly. Never threaten the patient, either verbally or physically. Now, physical factors. Literal noise, sounds in the environment, lighting, distance, or physical obstacles may affect your ability to communicate. Cultural norms often dictate the amount of space or proximity between people when communicating. Gestures, body movements, and attitude toward the patient are critically important. Now, verbal communication. When we're asking the patient questions, generally we want to ask open-ended questions for them to go into detail in terms of what is happening. So generally it's going to be open-ended questions, but there are patients that you will consider close-ended questions for based on their presentation. Asking questions is a fundamental aspect of pre-hospital care. Open-ended questions require some level of detail. Use whenever possible. Example, what seems to be bothering you? Now, close-ended questions can be answered in very short responses. Response is sometimes a single word. Use if patients cannot provide long answers. Example, are you having trouble breathing? No, I'm not seeing my slide clearly. What's going on here? Communication tools is what's supposed to be on this slide, but for some reason I'm not seeing it clearly. Not sure what happened to that particular slide, but I'm not seeing this slide clearly. All right, interviewing techniques. When interviewing a patient, consider using touch to show caring and compassion. Use consciously and sparingly. Avoid touching the torso, chest, and face. Interviewing techniques to avoid: providing false assurance or reassurance. So if don't tell the patient something that you're not sure about. And if you don't know, you don't know. Providing false assurance or reassurance, giving unsolicited advice, asking leading or biased questions, talking too much, interrupting, using why questions, using authoritative language, speaking in professional jargon. So you need to break down the communication to the level of the patient. Go ahead, Mr. Fisher.
I'm sorry to be asking a question so early, but why is it important to not touch the torso? I thought that was a very assuring way of calming down a patient.
Would you want to put your hands on a female's chest to calm them down?
Well, when you said torso, I wasn't targeting the chest area mostly. Probably like the shoulder.
The torso is the chest, abdomen, and pelvis without your attachments.
All right, copy that.
So torso is chest, abdomen, pelvis without the arms, legs, and head.
Thank you, sir.
All right. Presence of family, friends, and bystanders. Friends and family may be valuable during the patient interview process. Allow the patient to answer, even if well-meaning family members attempt to answer for the individual. Do not be afraid to ask others to step aside for a moment. All right, now golden rules. Make and keep eye contact at all times. Provide your name and use the patient's proper name. Tell the patient the truth. Use language the patient can understand. Be careful what you say about the patient to others, and be aware of your body language. And also just keep in mind that the patient doesn't have to be fully alert and oriented to hear what you're saying. So the patient might not be responsive and they can still hear you. So always be professional in how you're communicating. Speak slowly, clearly, and distinctly. If the patient is hard of hearing, face the patient so that they can read your lips. Allow the patient time to answer or respond. Act and speak in a calm, confident manner. All right, now communication with your geriatric population or older patients. You're gonna have to be very, very patient with these patients. So patience is a must for these guys or patient group. Identify yourself, present yourself as a competent, confident, and caring individual. Do not assume that an older patient is senile or confused. Be prepared to spend some time with these patients. You may encounter hostility, irritability, and some confusion. Do not assume that this is a normal behavior. Approach an older patient slowly and calmly. Allow plenty of time for the patient to respond to your question. Watch for signs of confusion, anxiety, or impaired hearing or vision. The patient should feel confident that you are in charge and that everything possible is being done for him or her. Be patient. So say, be prepared to spend some time with these patients. Older patients often do not feel much pain. They may not be fully aware of important changes in their body systems. You must be especially vigilant for objective changes. And objective information is what you observe. Subjective is what the patient tells you. So use your observation skills. When possible, give patients time to pack a few personal items before hospital. Might not be possible in all cases, but you will definitely have some where, yeah, you're gonna be there for a while. I can remember one particular call that I had with a geriatric patient complaining of something being stuck in his throat. Nothing was in his throat, but he was convinced that something was stuck in his throat. Took us about 2 hours before we left that particular scene. So yeah, if it's possible, because it took us 2 hours because we had to ensure that the pets were fed, the plants were watered, clean up stuff, help him find him Bible. Yeah. So you may be there for a while, but in an emergency situation, you're going to move with a sense of urgency. Locate hearing aids, glasses, and dentures before departure. Older patients are often worried about the safety of their home, valuable items, and pets. Emergency situations for children. All right, so communicating with children. It's going to be specific to the age group that the pediatric patient falls in. So you have your very young pediatric patients and you have your older pediatric patients. Emergency situations are frightening. Fear is most obvious and severe in children. Children may be frightened by your uniform, the ambulance, the crowd of people gathered around them. Let a child keep a favorite toy, doll, security blanket. The service that I was working with in Texas, we had there was a section on the unit that had toys that we could give to the young pediatric patients as a distraction. So that's a good thing to have on the unit. If possible, have a family member or friend nearby, especially if it's a young pediatric patient, because they may be valuable to you in terms of calming the child and also holding the child that you can do your assessment. If practical, let the parent or guardian hold the child during evaluation and treatment. Be honest. Children easily see through lies or deception. So you explain to them what is going to happen, and sometimes you have to demonstrate exactly what is going to happen. Hey, going to be putting a cuff on your arm, just like how it's on my arm. And depending on the age group, sometimes you have to give them choices that you control the outcome, right? So you want a specific outcome, but you're giving them a choice to include them in the decision. For instance, I have a young pediatric. Hey, I'm gonna give you a present. I'm gonna put something on your arm, right? It's gonna inflate with pressure or air, and then I'll be able to get a reading, right? See, this is a cuff, right? Which arm you want it on, your left or your right arm? So I'm giving them a choice, but I am controlling the outcome. Be honest. Children easily see through lies or deception. Tell the child ahead of time if something will hurt. Respect the child's modesty. Speak in a professional, friendly way. Maintain eye contact. Position yourself at the child's level. Communicating with hearing impaired patients. Most have normal intelligence and are not embarrassed by their disability. Position yourself so the patient can see your lips. Hearing aids, be careful that they are not lost during an accident. They may be forgotten if the patient is confused. So make sure you examine that environment very carefully. Ask family about the use of hearing aid. Now, the stethoscope can be used as a hearing aid, and again, the service that I was working with in the States, there's usually a lot of steths, more than one steths available, so you can actually put the earpiece of the stethoscope in the patient's ear and talk in the diaphragm, and it acts as a hearing aid. Steps to take to efficiently communicate with patients who are hard of hearing. Have paper and pen available. If the patient can read lips, face the patient and speak slowly and distinctly. Never shout. Now, listen carefully, ask short questions, and give short answers. Learn some simple sign language, useful to know signs for sick, hurt, and help. Ask the patient, okay, communicating with the visually impaired patients. Now, with these patients, you need to explain clearly what is going to. So, somebody has their mic open. Miss Kerr. Okay, sorry about that. Ask the patient if he or she can see at all. Visually impaired patients are not necessarily completely blind. Expect the patient to have normal intelligence. Explain what is going to happen. You're gonna have to act as a guide for the patient to some extent. If you move things around in their location, you have to put it back, right? Because their environment is set up a particular way in which they can navigate it. Some of them will have guide dogs, if possible. We are required to transport the dog with the patient to ease stress and discomfort for both the dog and the patient. If it's not possible, then we have to make arrangement for transport for the guide dog. So explain everything you are doing as you are doing it. Stay in physical contact with the patient as you begin your care. If the patient can walk to the ambulance, place his or her hand on your arm. So you need to act as a guide for the patient. Transport mobility aids such as cane with the patient to the hospital. Guide dogs easily identified by special harnesses. If possible, transport dog with patient, alleviate stress for both patient and dog. Otherwise, arrange for care of the dog. Non-English speaking patients. You must find a way to obtain medical history. And this is where you have to use your observational skills. Find out if the patient speaks some English. Use short, simple questions. Point to parts of the body. Have a family member or friend interpret. And sometimes the interpreter English is not that great either. So as I say, you need to really look at the patient and use your observational skills. Consider learning some common phrases in another language that is used in your area. Pocket cards that show the pronunciation of terms are available. Use a smartphone app or website to help you translate. Remember to request a translator at the hospital. Now, communicating with other healthcare professionals. Your reporting responsibilities do not end when you arrive at the hospital. So when you reach the hospital, you have to find the nurse or doctor that is going to receive the patient from you, and you need to give them a verbal report on your patient, and that usually entails what the patient told you, what did you observe, what did you do based on your observation, how did the patient respond to your management. And if you're en route to the facility, you would give them the method of transportation. But generally, you want the patient's chief complaint, what was your assessment findings, what did you do based on your assessment findings, how did the patient respond to that. And as I said, if you are en route, you would give them the method of transportation. Are you using lights and sirens? Are you only using sirens? Is it non-emergency transport? Give an oral report to a hospital staff member who has at least your level of training or higher. And give your report. Give your report. Right? Now, we used to have, I don't know what it's like now because I have not done an emergency transport for a patient, I would say well over maybe 5 years now. So I don't know what it's like in Jamaica, right? Over the past 5 years, I haven't done any emergency transport to the hospital. But prior to that, I've had EMTs express that sometime when they go into the facility, the nurses or the doctors not paying attention to the report. It's like they're rushing them to, hey, get the patient over there. It doesn't work like that. So legally, I am required to give you a verbal report before you sign my written report. So I'm not going to move any patient until I have given my report and you got the information that I am giving you. It is important. It is important. So if I bring in a patient to the hospital and I am giving the nurse or doctor a report, and they are rushing me to move the patient over to wherever, and I move that patient, they're going to end up repeating my assessments and management. So you need to know what I have done for the patient and where the patient is at in terms of trending up or down. So my information is important because you are going to use that as your guide to decide where you will start your treatment for the patient, right? And I always say to my EMTs or responders, if you are in your profession, right? So you're in your profession and you're following your standards, nobody should be telling you how you should be doing your job, right? So if you're following the correct standards, nobody can tell me to do it differently because I'm following the standards that is legally required. So you cannot tell me that I should be doing something else, right? So that oral report comes first, then the written report, the sign, and the patient is no longer your responsibility. Now, oral report components, opening information, name, chief complaint, illness. Detailed information not provided during the radio report. So things that you couldn't give during the radio report, you're going to give that, you're going to put that in your oral report. Any important history not already provided. Patient response to treatment given en route, vital signs, and other information. And if your patient is critical, the goal is to have at least 3 sets of vital signs. And with 3 sets of vital signs, you'll be able to determine if your patient is trending up or down, or if your patient is decompensating or compensating or getting better. Now, patient care report, also known as a pre-hospital care report, it is a legal document. Records all care from dispatch to hospital arrival. So the time that the call come in, the time that you were dispatched, the time that you arrive on location, how long you spend on location, the time you leave location, the time you reach the hospital. That is captured in the PCR. There are 2 types of PCR. You have written. Written is used more in Jamaica. In the first world system, it is all digital. So it is a digital system in the first world system. The PCR serves 6 functions. Continuity of care, as I stated earlier, when I give the physicians and the nurses an oral report or my PCR, it is for them to understand where I'm at, where the patient is at in terms of care provided and what they need to do to build on that. But it shouldn't be that they are starting over things that I've already done. That is not good for the patient's prognosis. It is legal documentation. It is used for education purposes, administrative information, very important to research, which is very limited in Jamaica in the field of EMS. Evaluation and continuous quality improvement. And I think there was a presentation done that by Dr. Campbell, who is the acting EMS director for the Ministry of Health. And I believe it showed a lot of deficiencies in documentation for the JDF, the JFB, and private ambulance companies in Jamaica. So we need to tighten up the documentation. I believe the private ambulance setting documentation was closest to 100%. It wasn't 100%, but I think it was about 90. So the other organizations are not capturing data properly. It is a legal document. If it wasn't documented, it wasn't done. So that's something we need to work on for sure. Information collected on the PCR should include the patient's chief complaint, their level of consciousness, which is, are they alert and awake? Their mental status is specific to their level of orientation. Are they oriented to person, place, time, and event? Their vital signs, their initial assessment, and the patient demographics. Administrative information gathered from a PCR includes the time that the incident was reported, the EMS unit was notified, the EMS unit arrived at the scene, the EMS unit left the scene, the EMS unit arrived at the receiving facility, patient care was transferred. So all of that information need to be captured on the PCR. Proper spelling, proper grammar. If you don't know the proper spelling for the word, use Google. Google is your friend. And if you don't know the proper pronunciation of the word, you can type the word in YouTube and get the pronunciation. I've seen a report where a supervisor, this is supervisor in quotation, a supervisor wrote in the report, and this is in Jamaica, that the patient was transported in the flowers position. What is the flowers position? I've never heard of that. So if you don't know how to spell the word or you can't remember, the patient was transported in a seated position with the stretcher at a 45-degree angle. Don't know the word spell, don't use it, right? When a lawyer is looking at a PCR report to decide if they are going to take a case, they look at whether or not it is meticulous, are there spelling errors, are there inconsistency, are there personal opinions in this? That's how they're going to decide if they're going to take that case. Now, types of forms. Traditional written form with check boxes, narrative section, or you have the computerized version, which is using the first word system. And the digital device that we were using to do our reports. When I type up my report on the device, I was able to send it directly to the receiving facility. And if I had my patient on the monitor has a Wi-Fi link to my reporting device. I don't remember what the name of the device is. It's a computer type device, but it's more sturdy than a computer. So any information I capture on my cardiac monitor would be transferred to that device automatically. No, that is definitely not available in Jamaica, so everything is captured on paper for now. Now, the narrative section of the PCR. Elements of the narrative section, time of the event, and The time that is utilized on a PCR report is Army time. So Army time is what is utilized in EMS report. Time of event, assessment findings, emergency medical care provided, changes in the patient after treatment, observation at the scene, final patient disposition, refusal of care, staff person who continued care. Include significant negative findings and important observation about the scene. Do not make any judgments. So do not put your assumptions or personal opinion in your PCR. Only put facts. What do I mean by that? So let's say your patient had a breathing rate of, so you have an adult patient and the patient had a breathing rate of 20 breaths per minute. I'm not going to put that the patient was breathing normal at 20 breaths per minute. I'm not going to put that. I'm going to put the patient had a breathing rate of 20 breaths per minute. It was regular, non-labored, no abnormal lung sounds without auscultation, visible chest rise bilaterally. I'm not going to say it was normal, it was good, it was ideal. Put facts. So you only put facts in your report. Do not put assumptions. Do not make any judgments about the patient's condition. Avoid radio codes and use only standard abbreviations. Remember that the report itself is considered a confidential document. All right, now reporting errors. If you leave something out or record it incorrectly, do not try to cover it up. Do not put lies in your report. Do not make up vital signs. And I can tell you based on what I've observed in Jamaica, we are famous for making up vital signs, especially the breathing rate. Do the checks, people. It doesn't take a lot of time to do it. Get your checks done. Do not make up stuff and put in your report, because someone who is very experienced and knowledgeable in the field of medicine will be able to look at your report and the patient presentation, and they can pick up that the vital signs just don't match. Something is off. So don't put lies in your report. That's very unprofessional. And we have zero tolerance for that, right? So it would be like you cheating in the course to pass. So if we discover that you're cheating, you're out. You cannot come back to us for any courses down the line. And if you're being evaluated, so if I am evaluating you for a practical and I observe that you're making up the vital signs, that's it. Zero tolerance, right? So once I am questioning your credibility, you're not fit for EMS. And I am very crafty. So remember that I was an EMT student as well, and I was a correctional officer. I have superb hearing, and I can pick up hints as well. Right? So don't tell any lies, please. If you leave something out or record it incorrectly, do not try to cover it up. Falsification results in poor patient care, may result in suspension and or legal action. Right? You might end up losing work. You may end up in legal troubles as a result. Please, don't tell lies, people. Don't tell lies in your report. If you didn't do it, you just didn't do it. If you discover an error as you are writing your report, draw a single horizontal line through the arrow, initial it, and write the correct information next to it. Do not try to erase or cover the arrow with correction fluid. Don't use any whiteout in your report. Now, common source of lawsuits, refusal of care. So this is a tricky one, right? And most lawsuits come from this area when persons refuse care. Through documentation, thorough documentation is going to be crucial. So when a patient is refusing care, make sure that the documentation is very detailed. Ensure that the patient understands the consequences, even if it is death, for refusing care. Ensure that that is clearly understood. Document any assessment findings and emergency medical care given. Have patients sign a refusal of care form. Have family member, police officer, or bystander also sign as witness. Complete the PCR. All right, now special reporting situations. Special reporting situations. Go ahead, Mr. Moran.
Yes, sir. At the ending of the patient report, sir, I heard that EMT said that it's good to sign at the ending of your report. That if that's legal, I just want to know.
I don't understand. You have to put your name on your PCR report. So
Yes.
I don't understand what you mean by sign.
As in, at the bottom of the narrative, you would
Yes.
make a signature at the bottom of your full stop, and then you make the signature right there to say that your report is finished there.
That's fine.
Okay, sir.
That's fine. All right, now depending on legal requirements, local requirements. So gunshot wounds, yeah, these are special reporting situation. Dog bites, some infectious diseases, suspected physical or sexual abuse, multiple casualty incident, MCI. So the organization will have special reporting requirements for these type of situations. Now, communication system and equipment. I'm not going to be spending a lot of time on this section because I sent out a handout for radio communication with the terms that are utilized for radio communication. Ensure that you go through that handout. Now, radio and telephone communications link you and your team with other members of the EMS, fire, and law enforcement communities. It helps the entire team work together more effectively, and it provides an important layer of safety and protection. You have base station radios. A base station contains a transmitter and a receiver at a fixed place, and two-way radios consist of a transmitter and receiver. Mobile and portable radios. Mobile radio is installed in a vehicle. It's used to communicate with dispatcher and medical control, and ambulances often have more than one. Now in Jamaica, the radio communication is not common throughout the various EMS organizations. The use of the cell phone is more common. I mean, you can get into more detail with the cell phone, but that is more common in Jamaica. Portable radios are handheld devices, essential at scene of an MCI, helpful when away from the ambulance to communicate with the dispatcher, another unit, or medical control. Repeater-based system. A repeater is a special base station radio. It receives messages and signals on a specific frequency, and then it retransmits that message on a different or second frequency. It allows two mobile or portable units that cannot reach each other to directly communicate using its greater power and antenna. Now, digital equipment. Digital signals are a part of EMS communications. You have telemetry, which allows electronic signals to be converted into coded, audible signals. Signals can be transmitted by radio or telephone to a receiver with a decoder at the hospital. Data from cardiac monitors can be transmitted via Bluetooth-enabled mobile devices. Cellular satellite telephones. EMTs often communicate with receiving facilities by cellular telephone, and that is more commonly used in Jamaica. I'm not saying that there are not services that have the radio communication. It's simply low power portable radios. Satellite phones are another option, can be easily overheard on scanners. Other communications equipment. Ambulances usually have an external public address system. EMS systems may use a variety of two-way radio hardware. You have simplex, which you push to talk, and then you have to release to listen. You have the duplex, which can do both simultaneously because there are two frequencies. And you have multiplex, which combine two signals on one frequency. So you can combine more than one signals on one frequency. Med channels are reserved for EMS use. Trunking system use the latest technology to allow greater traffic. And interoperable communication system allows all of the agencies involved to share valuable information in real time. Mobile data terminals inside ambulance receive data directly from dispatch center and allow for expanded communication capabilities. So there's a digital device in the unit that the information, some of the initial information for the call will come into us before dispatch even contact us to let us know that we need to respond to XYZ location. Now in Jamaica, there's no dispatch system. So there's no central dispatch system in Jamaica. There's no number to call to get a government ambulance response. No 119 dispatch for ambulance or 110. I think 110 would be ambulance, but if you dial 110, you're not guaranteed that you're going to get any ambulance. They may tell you that you need to call the nearest station that has an ambulance available, or they might tell you to call a private ambulance. So we don't have a proper dispatch system in Jamaica. The Federal Communications Commission regulates all radio operations in the United States. It allocates specific radio frequencies, license call signs, establishes licensing standards, and operating specification. It establishes limitations for transmitter output and monitors radio operations. Now, responding to the scene. The dispatcher receives and determines the relative importance of the 911 call. So the call, there's an incident, the call goes to the central dispatch. There's an EMD present, emergency medical dispatcher, who will gather the information for that call and then decide what type of EMS response is needed, whether it's BLS, ALS, whether fire is needed, whether police is needed. The dispatcher selects, dispatches, and directs the appropriate EMS response. Now, while the EMS response has been dispatched, the dispatcher is also able to communicate with the caller to provide some level of assistance to the patient until EMS arrives, or they will have specific instructions to give to the caller. They coordinate with other public safety services. They provide emergency medical instructions to the telephone caller. Oops, too fast, backtrack. All right. Responding to the scene. EMTs report any problems that took place during a run to the dispatcher. EMTs inform the dispatcher upon arrival at the scene. So you need to let dispatch know when you arrive on scene. And dispatch is going to give you a time, and you copy that time. The principal reason for radio communication is to facilitate communication between you and, communication with medical control and hospital. The principal reason for radio communication is to facilitate communication between you and your medical control. Medical control may be located at the receiving hospital. So your medical control might be at the hospital that you're transporting the patient to, or at another facility. The medical control is essential to proper EMS operations. Absolutely essential. Because in EMS, we have black, white, and we have gray areas. So there are calls in which you will need your medical control advice. Give you a simple example. You have a patient with suspected spinal injury. You have done your jaw thrust to open the patient's airway, and it's not effective, right? So you're doing a jaw thrust and it's just not effective. This might be a situation where you might need to inform your medical director to get permission to do what we would call a controlled head tilt chin lift. So you're gonna have calls in which your black and white is not clear, or you may have exceeded the requirements for your protocol, right? So for example, you have a patient who is in anaphylactic shock, which is from a severe allergic reaction and requires epinephrine administration. As an EMT, you're allowed to give up to 3 doses of epi-IM. You have given your 3 doses of epi-IM, that's your standing order, and it doesn't work. This is where you're gonna need medical control advice. So you have to call medical control and let medical control know that you have exceeded the dose required based on your standing order. I am awaiting further instructions because the patient is not responding to the epi after 3 doses. Right? So there are situations in which you will definitely need guidance from a medical director. Consulting with medical control serves several purposes. It notifies the hospital of an incoming patient. It provides an opportunity to request advice or orders from the medical control, and it advises the hospital of special situations. Now, giving a patient report. Follow the established format and include your unit, identification, and level of service. Unit number 20, ALS response. The receiving hospital and your estimated time of arrival. The patient's age and gender. The patient's chief complaint. A brief history of the patient's problem, a brief report of the physical findings, a brief summary of the care given, a brief description of the patient response to treatment. Now, the role of medical control. The medical control can be either offline, which is indirect, or online, which is direct. So offline would be standing order, protocol, right? Protocol, you have a patient who is not breathing, no pulse, start CPR, use an AED for the first 6 minutes of the code, and then go into ALS intervention. So that's a standing order. You have a patient who presents with wheezing and is on oxygen and it's not improving, administer albuterol and atrovent nebulized. So that would be a standing order. Online is when you contact medical control via radio or phone to get instructions directly. You may need to call medical control for permission to administer certain treatments, determine transport destination of patients, to stop treatment, and or not transport a patient. In most areas, medical control is provided by the physicians working at the receiving hospital. Now, there is a misconception in Jamaica. A lot of persons believe that once you have a medical doctor, that's a medical director. No. So it can't just be any medical doctor. It has to be a doctor who is a trained ER physician consultant with a background in EMS care, right? So with a background in EMS care or has completed studies in EMS. That is the requirement for a medical director. So you cannot be a doctor with no knowledge or experience in how a EMS system work, and then you're going to be responsible for creating protocols for EMS responders to respond. It just does not make logical sense, right? So you have to have a understanding of how the EMS system operates. So it cannot be just any physician. Many variations have developed across the country. The link to the medical control is vital to maintain a high quality of care. And if it's a very big service, so if it's a big service, you will have a medical director. So you can have an EMS medical director who is responsible for the quality of care. And then you'll have a EMS director, which is usually a paramedic with a Bachelor of Science degree or a paramedic who has extensive critical care training to manage the field operations or supervise field operations. So it can be a combination of both. Now, calling medical control. There are a number of ways to control access on ambulance to hospital channels. The dispatcher monitors and assigns appropriate clear medical control channels and centralized medical emergency dispatch or resource coordination centers. The physician bases his or her instructions on the information the EMT provides. So the medical director cannot see this patient in front of them. You are seeing the patient. So your assessment must be thorough. It must be meticulous, right? So that the information that you're providing to your medical control paints a clear picture in their mind in terms of what is going on, and they can advise you accordingly. Never use codes unless directed to do so by local protocol. Repeat orders back word for word and then receive confirmation, right? And you can have a situation where you give your medical control information and they give you an instruction, but the instruction that you got, it's not safe for the patient. You can refuse to carry that out and do what is best for the patient. When you get back to your base, you can have a discussion with your medical control, because again, they are not in the field, you are. And sometimes they don't hear clearly what you said, or they misinterpret what you said and give inappropriate instructions. That's fine. We can have a civil discussion when we get back to base. But I will never, ever do anything that I think is going to cause harm to my patient, even if it is an instruction from my medical director. Not gonna happen. So repeat orders back word for word and then receive confirmation. Do not blindly follow an order that does not make sense to you. I already expounded on that. So if you don't think it's safe for the patient, don't do it. Information regarding special situations. You may initiate communication with hospitals to advise them of an extraordinary call or situation. And examples of these situations would be hazardous material situations, rescue in progress, multiple casualty incidents. Keep several points in mind. The earlier the notification, the better. Provide an estimate of the number of patients, identify any special needs, and follow your system plan. Maintenance of radio equipment, like other EMS equipment, radio equipment must be serviced. The radio is your lifeline to other public safety agencies who protect you and to medical control. At the beginning of your shift, check the radio equipment. Radio equipment may fail during a run. Backup plan must then be followed, may include standing orders. Right? And that would be the end of communication and documentation. Let me plug this in. All right. Question 1. Question 1. Go ahead, Ms. Beckford. Ms. Beckford, you had your hand raised. Go ahead. Cultural imposition. D is correct. Go ahead, Mrs. Morgan, you have your hand up.
A, approach the patient slowly and calmly.
Okay. That is correct. Number 3, while caring for a 5-year-old boy with respiratory distress, you should. Okay. Let's see. D is correct. D is correct. Number 4. B, the patient's family medical history. Let's find out. B is correct. All right. Number 5. Which of the following statements about the patient care report is true? Okay. All right. C is good. C is good. All right. Number 6. A device that receives a low frequency signal and then transmit it at a relatively higher frequency. Not sure if you guys are going to get this one, but anyway, give it a try. All right, I'm seeing A and C. C would be correct. So C is a repeater. That's what it is, a repeater. When treating a potentially hostile patient, you should try to diffuse the situation by okay. C, I'm seeing a lot of C's. C as in cat would be correct. Number 8. All of the following are functions of the emergency medical dispatcher except pretty straightforward question. Read the question carefully, people. Read the question carefully. All of the following.
D.
I hear someone said D. Who is that? Is that Mr. Sewell? Okay, noted. Right, so y'all need to ensure that you read the question correctly. All of the following are functions of the emergency medical dispatcher. That means 3 of these possible information. 3 of these. Because we have A, B, C, D. 3 out of this 4 are going to be things that a dispatcher would be doing. The question is asking for the exception. Okay, it's asking for the exception, which is something that the dispatcher would not be doing. Ensure that you read your questions carefully. Do not misinterpret the questions. It's multiple choice. You can only get one right answer. That can mean the difference between 69% and 70%, and I will only accept 70%. Okay, now number 9. After receiving an order from medical control over the radio, the EMT should. Now, anytime you see the word you should or the EMT should, it is asking for the next step in a sequence. So when you read a multiple choice question in EMS and it has the word you should, it is asking for the next step in a sequence. So you have to know the sequence in order to get the question correct. D would be correct. Number 10. When requesting medical direction for a patient who was involved in a major car accident, the EMT should avoid. When requesting medical direction for a patient who was involved in a major car accident, the EMT should avoid. I see somebody have A, I see B. What should the EMT avoid? You're talking to your medical control. So I'm talking to my medical director. What do I need to avoid? The answer would be A. So we need to avoid using codes, right? Because I need to ensure that my medical director has a clear understanding of what is happening. All right. And that would be it for communication and documentation. We are going to break